prize today. Thank you for hosting this. Really appreciate it. Great venue, great people. Wish we could go to the beach later. Is that too loud, Chief? Are we good? Good, sweet. Well, my name's Will Ferguson. I'm an ER doc out of Birmingham. Previous life, I did EMS work. And don't throw things at me. I also did about 14 years of ER and flight nursing before med school. I just look young and vibrant, okay? EMS Challenge, we started this several years ago, if you're unaware of it. And the goal of this is to bring physician-led Con Ed back out to EMS. I think the work that EMS does is physician-level care. And I think that as a whole, the system has kind of left you hanging dry as far as docs getting out and helping y'all. So that's one of the things we're trying to do. At UAB, we have a couple of fellows. Those are docs who've done 3 years of ER training after med school, who are doing an additional year or two of training in EMS. We also have our residents that are out in the BREMS region doing some training and working with you guys. But the challenge is brought about to improve patient care. You can read these slides. I won't go over detail about that. But the goal, again, is to get more physicians involved in EMS. For your certificate, for the folks here in person, you can scan the QR code on your table. If you're online, there'll be some information in the chat box. And you can always email alabamaemschallenge@gmail.com, but do that by this afternoon, we'll get your Con Ed. The ENA also sponsors us, and we have nursing credits. So if you're a nurse, we can give nursing CEUs as well. Things we got coming up in the future, March 23rd, we'll be at Birmingham, Station 2 Drills and Training, doing the lecture and labs. In April, the Critical Care Transport Medical Conference. That's usually most of the rotor wing agencies in the nation have a conference. It's gonna be in Orange Beach. So it's right in our own backyard, a few minutes from here. Some good Con Ed there if you're interested. In April is FDIC with the fire service and GEMSCON. They have merged together, and that'll be in Indianapolis. And then June, we hold our physician group. Alabama American College of Emergency Physicians holds a conference at Sandestin, and we have 8 or 9 states that are involved with that. And there'll be some EMS activities there if you're interested in that as well. And I guess the biggest news, if you haven't heard, the protocols are changing as of April 29th. Have y'all seen those yet? Yes, no? Anybody even care? Raise your hand if you don't care. I know somebody wants to raise their hand, you're just too scared. But short version on that is everything for medics is going category A except for pediatric intubation, kids less than 3. So if it's in the protocol and it seems reasonable to do so, you can do it without calling a physician. And my kind of sidebar on this is be careful what you ask for in life. You may get it. We've been asking for this for a while and now we got it. That's a lot of responsibility though. Okay, so I would recommend you review those protocols, make sure you know what you're doing. If you know what you're doing and you go category A on everything, great, but there's a lot of potential to hurt people, okay? Protocols are on the state webpage. The other cool stuff starting in April is the advanced EMT. We've expanded their scope due to a couple of reasons, but in short, the advanced EMT in April will be able to give nasal Versed for seizures. They can also give epi and cardiac arrest, IV, right? There's really limited risk to that and a great benefit. And then rumor has it there's a trial of ECG interpretation for advanced going on now, and that might be addressed in the future so that the advanced EMT can also transport folks on cardiac monitor, and they'll get training as far as rhythm interpretation, not 12 leads, but 3 leads. So a lot of stuff coming up, a lot more responsibility. So thank you for almost smiling. Good. All right. So older protocols, I didn't put the new stuff out. This is the EMT scope of practice. And the reason I want to kind of talk about this for a second is because the EMT scope of practice in Alabama is a little bit more detailed and expanded than anywhere else in the nation, for the most part. There's a lot of responsibility. The other issue I see is that a lot of places are having difficulty finding EMTs and medics. Are y'all fully staffed down here? Wow, I need to come down here and work for y'all. Very good, that's sweet. Most places I talk to are not fully staffed. There's a shortage out there. So you're seeing agencies that used to run a lot of ALS having a tiered response. So you got more of the EMT out there. You know, years ago, we called EMT basic EMT. Y'all remember that? Yeah, it's not called basic anymore, right? So no more basic. EMT is really high level care. There's a lot of things you got to be able to do. It's a 1 semester course, but the responsibilities are enormous, mainly because of this right here, patient assessment. So yes, we can teach people skills about how to do CPR. We can do first aid, some hemorrhage control, but recognizing a patient that's sick or not sick can sometimes be challenging. And I define sick or not sick as if sick is the person I look at And in my brain, I'm thinking, holy crud, they can die in the next 30 minutes or less. Okay, versus not sick, I got time to do a few things, make a decision, do you go to the hospital with me or somebody else, or what do I do? But sick or not sick is pretty hard to do sometimes with some patients. So a few things I think about when I'm talking to the EMTs or even the advanced or the medics is good patient assessment skills. It's deep. There's layers of therapy that you got to think about. Some of the skills that I learned in the EMT class 30-something years ago, I still use now in the ER, even in a doc, right? So if I'm gonna go intubate somebody, all right, before I start pushing drugs to make them where I can intubate them easily, I got an oral airway in my pocket. So I know if I can't get them intubated, I can pull that OPA out. I know how to use that and I can ventilate somebody. So the skills that I learned as an EMT still help me today. I just have more tools, more medicines, more cool things to play with. But patient assessment's pretty important. For example, respiratory rate. People get caught up on this. And I can tell you that in the ER, when I'm looking at a triage note, most people have respiratory rates of 14 if they're normal. They have a respiratory rate of 0 if they're dead. Or if they're complaining of shortness of breath, they have a respiratory rate of 20 plus. So rate doesn't give you a lot of information. Now, obviously the extremes matter. Somebody breathing 6 times a minute, scary. Somebody breathing 30 times a minute, scary. The in between though really doesn't matter. It's more of a work of breathing, right? So if they're using accessory muscles, if they got nasal flaring, if their head's bobbing, if they can't tell you a story, if you ask them Alabama or Auburn and they can't tell you which one because they're so short of breath, you know they're sick, right? That was funny, people. Come on. All right. So work of breathing is more important than rate of breathing, except for the extremes. Heart rate is different than pulse rate. A lot of people look at a heart rate and they calculate that by the monitor when you put it on there. In reality, you should lay hands on your patients to get a good pulse rate, a little bit different, right? You may see a cardiac monitor rate of 140, 120, but then you touch the patient and the radial pulse, you don't feel anything. They're sweaty, they're clammy. That tells you they got way poor perfusion, they're unstable. If they're talking to you, they obviously have a pulse though, right? So then you work your way up. You check a brachial, you check a carotid, you check a groin, and you move that way. So patient assessment is really important. Have y'all heard about the pediatric assessment triangle? Yes. So that's something that they put out for peds years ago. It's work of breathing, skin color, and general appearance. General appearance being the most important part, right? So if you walk in on scene, looking at someone, if they're talking to you, they're smoking a Marlboro, they're probably okay for a few minutes, right? If they're altered, they got the Q sign, a little bit different. So general appearance is important. Work of breathing is really important. And then kids, skin color is great because you don't have 40 years of Crystal Burgers and Busch Light with those guys, right? All right. But cap refill, skin color, perfusion, radial pulse, central versus peripheral, those things are pretty important. When I think about assessment and mental status, yeah, we can go really deep into these stroke scales, but my first primary exam is the AFU. Are they alert? Are they talking to me? Do they respond only to a quick sternal rub, which we don't do anymore? Wink, wink, right? Are they unresponsive? And temperature, I know with COVID, we've been stressing these fevers. Who here actually checks temperatures on patients in the pre-hospital environment? Oh, wow, good answer. Okay, I was gonna put my hand down because I don't. I basically kind of look, do you feel like you have a fever? I touch them. If you can cook an egg on them, they're too hot. If they're cold and stiff, they're too cold. Everything in between for your primary exam, in my opinion, is probably reasonable, right? COVID did change that somewhat. Other things I want to kind of mention quickly is talking about getting a history on people. I call it the STMs, the stuff that matters. So anybody ever been to a patient's house and you start asking past medical histories and they say, yeah, I'm on vitamin D, I'm a multivitamin, I take ginseng, I take the little blue pill that helps you do things, I got a Walmart bag of medicines, right? That stuff is not super beneficial for us. It takes too much longer. It takes too much time to get that information. So I think about things that matter. The purpose of a history is not to get all the information to fill out the chart. The purpose of your history is to risk stratify your patient to determine if they're sick or not sick. So I'm dispatched to a chest pain. I walk in the house with a 40-year-old male and he's got chest pain. I don't care if he's on anti-arthritis medications, if he's on Motrin. I don't care about his vitamins. Important things I want to know is, hey, sir, have you ever had a heart attack before? Any cardiac history? If he says yes, that tells me he's higher risk for having more cardiac problems. And so I'm going to be faster with my hands on to get in my 12 lead. Does that make sense? All right. So there are important questions to ask for acute coronary syndrome. I would say any history of heart disease, yes or no. I ask about diabetes, and then I don't want to know what medicine they're on because there's too many medicines out there. My question is, do you take shots or pills?
They take shots. They're probably a type 1 diabetic or an older type 2. They're higher risk for big cardiac problems. If they take pills, they're probably just type 2 and less risk for heart problems. So in my mind, I'm still going to do the same workup, but I address or base my speed is how I take care of the patient based upon their history. That's the purpose of a history for you and for me. Does that make sense? We're not the primary care. I don't care about the other things. I do care deeply, right? But I don't care right now. Shortness of breath, things I would ask. I'll be any history of heart failure, all right? That would let me know that that's a high risk for that patient. People who have asthma or COPD, the first question I ask them after I ask that, and I know they have that history, is have you ever been admitted to the hospital for that? Because people who have been admitted to the hospital for asthma or COPD, high risk to have real disease, be admitted again. The next question is, you ever been admitted to intensive care? And if they say yes, the risk of them being readmitted to an ICU or reintubated for asthma or COPD is about 50%. So those folks are super high risk, and I'll be quick, aggressive, hands-on, start therapy maybe even before I get a complete set of vital signs. And in my mind, I've already got my transport decision made. They're going to be moving to the hospital because they're high risk of dying. Does that make sense? All right, sweet. The other things I think about is don't forget the underlying physiology, pharmacology, all right? And I say that for a couple of reasons. Tourniquets. So you have a guy that is using an industrial machine, gets his hand caught in it, pulls it out, and now he has an amputation from his wrist, and he's pouring blood out. Pale, diaphoretic, becoming altered. How do you manage that? What do you do for that guy after you cuss? Direct pressure. I'm good with that. Direct pressure. First guy in, direct pressure, right? So you've got your gloves on, direct pressure. What else are you going to do next? Tourniquet. Where's the tourniquet go on the arm? Yeah, high and tight, right? Okay. So don't forget the underlying physiology or anatomy, right? So you got two bones in the lower arm. You put a tourniquet below the elbow. You may slow the bleeding down, but you can't constrict those vessels well. You want it way high and way tight. I would argue that when I see him and I walk in the room, and I see that blood, yeah, I'm gonna do direct pressure. I may even lay him back and put my knee in his arm to cut off supply as I'm yelling for my buddies to go get me a tourniquet, all right? And I put that tourniquet on. I can't tell you how many times I see him put on right here. Doesn't do a lot of good. So don't forget the underlying principles in the therapy we give people. What if you have a guy that's stabbed in the neck and it's pulsating? What are you gonna do with that guy after you cuss? Yeah, so occlusive dressing, all right? I would say if it's bleeding profusely, I'm gonna have gloves on. I'm gonna be planning the fact that he's gonna be going to the hospital quickly. I'm gonna put fingers in the neck hole, try to stop the bleeding. If it's not bleeding quickly, I'm probably not gonna poke it and prod it. I may put the occlusive dressing on him as I'm moving toward the hospital. Or you can put a tourniquet on the neck. You can once, right? Then you're working at Walmart after you were 6 months in jail, right? You laugh, I laugh, it's funny. It's American healthcare, right? You laugh, but it's, I've seen people use Curlex or Cling on the neck to put a pressure dressing on a neck wound, and that's like a tourniquet. So think things through before you do it. What about the 40-year-old guy or 60-year-old guy? Well, I won't put an age. I'm gonna get in trouble. The mature gentleman that you pick up at the hotel room at 2 in the morning that is now having chest pain, and as you pull up, 3 ladies run out of the room. You walk in, he's hypertensive, he's got chest pain, his EKG is abnormal. What drug does he need for chest pain? Nitro. What is a contraindication to nitro? Right, so remember those things. A lot of medications out there have contraindications. One of the new drugs you'll be getting for pain control is called Toradol. It's a non-steroidal anti-inflammatory. You can give it through an IV, all right? Really doesn't hurt many people unless you're pregnant, but it could do bad things to the baby. Or you have kidney disease. It can really mess up your kidneys. So that drug's coming out to you guys. So you got to know those things. Everybody knows the nitro already, but there are a lot of drugs out there. And with stuff going category A, you got to understand that and know that. Now you can still call in med control and get help. I'm not saying don't do that, but I'm saying there's a lot of responsibility out there. How do you ask a guy if he's on Viagra? Politely and quietly. You clear the room, right? All right, I'll leave that one alone. Let's talk about some 12 leads for the medics in here. So 12 leads, in my opinion, are a screening tool. There are books out there. There's the Dobbins book, a lot of things talk about vectors and so forth, and I get all confused with that. So every 6 months, every year, I go back and I read about the vectors.
But you got to have a way to look at a 12 lead and recognize, is it STEMI or not STEMI? Is it scary or not scary? Okay. The manufacturers will tell you that 12 lead machines, the Life Packs, the Zols, the Tempest, whatever you got, they do a great job. 98% effective in reading these STEMIs. I would argue they're full of it. I think if we're at 70%, that's probably giving a lot of benefit to these folks. So that point being said, it's your job to be able to read a 12 lead as a medic. All right, because we can do things to fix STEMIs now. When I look at 12 leads, I look at a couple things. I say, is it too fast, too slow, or okay? Too fast rhythms, American Heart, I agree with that stuff. The narrow versus wide complex, regular versus irregular, I think they do it great. The too slow, I think about 3 things that cause somebody to be bradycardic that is not related to something you pick up on your primary exam. And that's gonna be drugs, electrolytes, or ischemia. Now, obviously, other things make you bradycardic. The 6-month-old that is blue with a heart rate of 40, what's their problem? Respiratory, right? So you can be bagging the crap out of them, opening the airway, aggressive airway management, give it a few minutes. The 16-year-old that's shot in the belly, that's talking to you with a heart rate of 130, and as you're talking, he gets more altered. Now his heart rate's 90, 70, 40. What's going on with him? He's dying, right? He's bleeding out. So other things can cause bradycardia, but you pick that up on your exam. Things you won't pick up on your exam will be drugs, electrolytes, or ischemia. All right? And then the okay-ish, that's the EKG that's between a 50 and 140 rate and looks okay-ish, right? So that's that patient we talked about, the respiratory patient kind of in the middle. Are they sick or not sick? Is this EKG concerning or not concerning? And those are some of the things you need to start thinking about being able to pick up as well. So quick refresher, know how to calculate a rate. Don't just trust the monitor. If the monitor's showing a rate, great, print off your 12 lead, calculate the rate. And as you print out the 12 lead, you lay your hand on the patient, touch the pulse. You can determine, is it regular or is it irregular? Is the skin warm and dry? What is their perfusion? Gives you a lot of data. Then calculate your rate. I use the box method. However you want to do it is fine. But I start at 1 QRS complex. Next box is 300. It's 150, 100. I can't remember. My ADH kicks in. I'm thinking about dinner. And then a few boxes later, that's probably way too slow, right? Whatever you can do, however you can do it, do it. Intervals, you got to know the PR interval, the QRS, and the QT. Those are pretty important. If you don't know what a wide QRS complex looks like, you can't use that too fast algorithm we kind of mentioned. What is the, if your PR interval is long, what does that tell you? First 3 heart block, right? That's what we all learned in medic school. What does a first 3 heart block do to somebody? Nothing. I like that expression. Yeah, it's like, man, I don't care. I care. It doesn't matter clinically right now. But a PR interval that's way long in a dialysis patient, what does that tell you? That tells you they're hyperkalemic. All right? So that PR interval, a wide PR interval, can give you some data besides the first 3 heart block. All right? The QT interval. If the QT interval is longer than half the QRS to QRS, the R to R interval, they have a long QT. The problem with that is people are prone to going into a funny rhythm that kills people. You know what that rhythm is? Torsades. Yes, thank you. Good. Yeah, torsades, right? So if you have somebody that's syncopized, they passed out, you get there, they're feeling better, they're there in the front yard, you do a quick 12 lead and their QT interval is 2 times normal, you can think, okay, yeah, they could have just passed out because they were dehydrated or had too many Bud Lights or they tripped, but their QT interval is long. They could have also had a run of torsades and converted back. So this person probably needs to go to the hospital, right? But if you don't understand what these normal intervals are, you can't pick that up, right? All right, so when I look at a 12 lead, I'm gonna look at this one, I'll say, is it too fast, too slow, or okay? There's a pointer on. So 300, 150, 100, don't care, don't care. So the rate's okay-ish, right? The machine says 70, I'm good with that. The next thing I'm gonna do, since the rate is okay, I'm gonna start looking for injury patterns. I'm gonna start looking for STEMIs because that's something we can fix. And I'll look at leads 1, AVL, and 5 and 6. All right, and that's my lateral leads. I'm looking for ST elevation. If I got ST elevation in any 2 of these, it's a STEMI. It needs to see a cardiologist. This patient is high risk of dying in the next couple of hours from VTAC, VFib, or complete heart block. One of the 2. I need to see a cardiologist. Next thing I'm gonna do is I'm gonna look at 2, 3, and AVF. Same thing for elevation is a STEMI. Depression is concerning for ischemia, but not a STEMI. These are my inferior leads. The next place I look is V1 through V4. These are your septal. These are your anterior. This is the biggest portion of the heart. You're looking for elevation there. If you got depression in V2, 3, or 4, that's a posterior infarct, just like a STEMI. Sometimes your machine will read that, sometimes your machine will not. So again, that's why it's pretty important that the medics be able to read a 12 lead, okay? Because we can intervene on this. When paramedicine was initiated, we couldn't do much for a heart attack. If you had a heart attack, we said, yep, you got a heart attack. We're gonna change your diet, quit smoking. I'm gonna hang some lidocaine in case you go into VFib or VTAC, and we'll give you about a week in the hospital. Hopefully you'll do fine. Those days are gone, right? We got drugs, we can light STEMIs, we can take you to the cath lab, a lot of things we can do that save people, and also not just save them, but get them back to doing good work, physical work. Last place I look is lead AVR. Now, I learned a long time ago, AVR was only good to look if your leads were on correctly. So if you are down in AVR, you're up in 1, my leads are on fine. And I did it. Sorry, Chief, I walked right in front of the projector. I can't be still. In reality, if you have ST elevation and lead AVR alone and depression anywhere else, that's the STEMI equivalent. That's somebody that's probably having a big heart attack, or somebody with bad heart disease who's now stressed out, hypotensive, dehydrated, septic. Maybe it's the 80-year-old person that just had a car wreck and they're bleeding out. They're kind of low volume. You'll see AVR start rising up like a big freaking STEMI. You'll see 5 and 6, 1 in AVL, depressed down, and you know something bad's going on. But I have this pattern that I do every time for every 12 lead. Look at it the same way. That way, when I'm tired and I'm working my 5th shift in a row and it's 2 in the morning, I'm not going to miss these things. All right. So same way I look at it. Once I go through looking at that, I go back to lead 2. I'm going to look at my intervals. My PR interval looks okay. My QRS interval looks fine. My QT interval is half the R to R, so it's reasonable as well. This is where I look for intervals. I look at lead 2. So that way I have the same way. If you have a different approach, no harm, no foul. Everybody does a little bit different, but I would recommend that you have the same way every time so that when you're tired, you don't miss something, okay? Does anybody work more than regular time? Anybody do any overtime ever? Raise your hand if you don't do overtime. Yeah, right. Yeah. You get paid for overtime down here? Okay. The boss says yes, right? So if the QRS is wide, I go to V1. And here's where we start looking about left and right bundles. And just this past year, I started adding this into the Con Ed that we're doing because I think it's pretty important. Most monitors, when they see a left or right bundle, they quit interpreting. So you can't tell if there's a STEMI or not. The machine won't tell you. And if you're living 4 minutes away from a cath lab center, not a big deal. But if you live in where there's not a cath lab center, or you got to make a transport decision, do I drive an hour or 15 minutes? It's a really big deal to be able to recognize those things. So this one, too fast, too slow, or okay. I'm gonna say it's 300, 150, 100, 70. Yeah, so it's okay, right? So maybe 100. Machine says 100. Sure, we can trust the machine there. But it's not too fast. Not greater than 140, not less than 50. I'm gonna start looking at injury patterns. I'm gonna look at 1 AVL and lateral. Does not look normal. It's a wide QRS. I can pick that up already. I got some depression here, but it's not a STEMI. But it makes me want to move a little bit faster on the patient because it's abnormal, right? So now I'm going to start asking more detailed questions. I'm going to call my partner, hey, maybe he needs a little bit of pre-oxygenation, right? Maybe somebody starts an IV and gets an AccuCheck, all right? And now I'm going to look pretty hard at this EKG, right? So 1 AVL and lateral, 2, 3 in AVF, same thing. No STEMI, but it's wide. V1 through V4. I would argue that you're elevated some there, you're elevated some there, maybe a little bit there, but not super bad, all right? No depression, last place is AVR, it's opposite there, low voltage, but not a STEMI, right? So the next thing I'm gonna do is I'm gonna go here and I'm gonna look for my intervals. So my PR interval is a little bit long, my QRS is wide, so if my QRS is wide, I have to go over here, I'm looking for bundle branch blocks, right? So this, if you have a deflection or downward pointing QRS complex, this is now a left bundle branch block. I think the machine actually said it too. Sometimes it will, sometimes it won't. So this is a left bundle. So when you have a left bundle, there are different ways we kind of look at a 12 lead to see if you're having a STEMI. Years ago, if somebody had chest pain, a left bundle, we didn't have an old EKG, we said they had a heart attack. So if you worked at a place that had medicines, they could take them to the cath lab, they would do that. Otherwise, we're pretty concerned. In 2013, the rules changed on that. Left bundles were not an automatic entry for a STEMI. They assigned something called scarbosis criteria, something we look at on 12 leads to say if they're having a STEMI or not. And scarbosis criteria basically says If you have discordance, it's good. So the QRS should be opposite the T wave, all right? And as long as you don't have concordant ST elevation, so QRS going down, T wave inverted, that's not a STEMI. And as long as in these 4 leads right here, V1 through V4, you don't have more than one big box of elevation, it's probably not an acute STEMI either, okay? Now I get it, I see some of your eyes kind of rolling over looking at me, I appreciate that, right? There's no way to learn 12 leads in one class. This is just a quick review for you guys. There's a Life in the Fast Lane is a good study source online. Wave Maven is another good one. I'll probably talk 12 leads at least 50% of the time in the Con Ed that we do, and they're on YouTube as well. And the only way you get better at 12 leads is look at a lot of them. So if you're not seeing 10 or 12 a shift where you're working or don't have time to look at it because you're working too hard, at some point in your career, your life, during the week, you got to pull up EKGs and look at these, okay? Otherwise, at some point, you're going to miss one and you're going to feel bad about it. So left bundle branch block is a wide QRS, downward deflection in V1. There's usually no Q in AVL either. Now, there's a lot of criteria out there. I cannot remember all that. There's no way. So I remember wide QRS, downward deflection in V1, and a no Q in AVL. But that's enough data to say it's probably a left bundle. Now I can apply scarbosa. All right, yippee. Good, thank you. The things that cause a left bundle branch block is anything that makes the left side of the heart get big. So chronic hypertension, new heart attacks, anything that makes the left side of the heart get big, jacks up the conduction system and it slows it down. And that's why you get that QRS. Yes, sir. Yes, sir. So the 2 sites, Life in the Fast Lane and Wave Maven, are 2 good ones. Life in the Fast Lane is EMS based. Wave Maven is a med school on the East Coast, but it gives you a scenario and an EKG. And I think that's important because you got to have a clinical picture to figure out what's going on, right? Yes, sir. Sweet. Scarbosas. Again, there's some new modified scarbosas out there. If you want to learn that and get fancy, that's fine. My practice, I think this is enough data for me to make a decision. Is this patient having a heart attack or not? And do I need to see a cardiologist right this minute or not? So on this one, I would argue that if it was not a left bundle, if this QRS was narrow, I would activate a cath app. I'd be calling a cards because of this. But because it is a left bundle, wide QRS, downward deflection in V1, this discord here, which is good, is not more than one big box. So he's probably okay. Now, he still gets his 12 lead. He still gets his aspirin. If he's having chest pain and not taking that little blue pill, he gets his nitro. He gets IV access. If clinically he looks like dirt and makes me uncomfortable, he gets defib pads and he gets pre-oxygenation in case he is having something bad and goes into cardiac arrest, right? But not a STEMI equivalent. This one, too fast, too slow, or okay rate-wise? Okay, yeah. That's between 50 and 140, looks okay. I'm gonna look at intervals, injury patterns. So I got 1 AVL and lateral, looks pretty good. 2, 3 and AVF are my inferiors. I got that T-wave inversion here. So concerning, but not a STEMI. I look V1 through V4. Does that make you uncomfortable? It should. That makes me uncomfortable just looking at it, right? So no elevation, but we got this depression here. So if this is a regular EKG, not a bundle branch, this is probably a posterior infarct. This is the STEMI equivalent. A lot of machines won't pick that up. There's some people that like to advocate about doing a posterior EKG in the field where you see this, so you want to see if they're having elevation. So you take the leads off V3 through 5 and you put them on the back, and you can run another 12 lead. That is way too fancy for me. It's also a waste of time in some situations, I would argue. I think if I see this, that's enough data for me to say, okay, this is most likely a posterior infarct. I'm gonna do my aspirin. I'm gonna get them put into the system so that we can get them to a cath lab hospital and start trucking down the road. All right, but every EKG, I go through the same pattern. So I've done V1 through V4. Now I'm sweaty. I'm moving faster. Next thing I look at is lead AVR is opposite of 1. So it's okay, and I don't see any big elevation. Next thing I do is I look at this lead 2. My PR interval looks fine, but my QRS is wide. So that tells me I have a bundle branch block. So I'm gonna go over here to V1. And now I'm pointing up. So bundle branch block,
And if you look at V1 and the QRS complex is going up, that's a right bundle branch block. Like you turn in right, driving down the road. Y'all use indicators down here in Enterprise. In Birmingham, we don't. We just cut them off the cars and we give you a gun. That's what we do. So this is a right bundle branch block. So the good news with this, with right bundle branch blocks, this is fairly normal, okay? So you get a right bundle branch block because the right side of the heart is jacked up. So for some reason, the right ventricle, right atrium is enlarged. It can be due to left-sided heart failure. The other common findings would be somebody who has COPD or pulmonary hypertension or pulmonary embolism, some reason to have bad lungs. You get a right side of the heart that gets enlarged and you get that right bundle branch block. So this EKG is fairly reassuring in a right bundle branch block, okay? Now, if my patient is sweaty, diaphoretic, looks like dirt, I'm still concerned. They still get their aspirin, their IV, their nitro, their pre-oxygenation. And when I get to the hospital, I'm still going to take this EKG up to the doc and say, hey, man, I got this 48-year-old guy saying he's got chest pain. He looks like crap. Will you look at this EKG? But with the right bundle, that's probably not a STEMI at this point. Does that make sense? Yes, no? Anybody even care? Look at this one. Too fast, too slow, or okay? So we got 300, 150, 100, 75, 60. Okay, so 60 to 70, that says 65. So I use the number 50. I think there are some people out there have heart rates in the 50s. They're older, maybe on beta blockers, or some of you healthy people can have heart rates of 50. If my heart rate's 50, I'm like dying in front of you. But so I still say it's okay-ish between 50 and 140. All right, so I'm gonna start looking at injury patterns. I'm gonna look at leads 1, AVL, 5 and 6. I'm gonna look at 2, 3, and AVF. I look V1 through V4. Then I look right here at AVR. Kind of hard to tell if it's opposite. It looks funky. All right, but AVR is there. But what do you think about this one? Concerning or not concerning? Very concerning. What do you see that's concerning there, sir? Right. Right. Cool. So this is a big ST elevation here, very concerning. If I go through my whole system and I get through at the end, I'm gonna look here, I'm gonna look, periamble's fine, QRS a little bit wide, so I'm gonna go over here. I point up. So I would say, even if I didn't know this is a right bundle, that's concerning, but this is a right bundle. And with a real right bundle, this should be lower than normal, right? So this is now super high. So that's a STEMI every day, right? Sometimes you'll see people with right bundles and they have a baseline ST complex right there and it looks normal, but you think to your brain, this should be depression. Why is that normal? Right? So that's the person that you just keep hitting the 12 lead. And if it really is a STEMI, over the course of the next few minutes, it's going to pop up and even the machine will recognize it as a STEMI. So that should be pretty concerning. So if you look at the interpretation of this by the machine, it says right bundle branch block. And does it say STEMI or acute MI? It does not. So you take care of this patient and you look at this and you read this and it says right bundle. You tell a guy, no, he's not having a heart attack. No worries. Here's you some aspirin. And you take your time loading him up. You grab his Walmart bag of medicines. You get his cat. You put it in the container for him. And, and then 15 minutes later, he starts having a seizure. He's actually in VFib, right? So it's important to pick these things up. This is super concerning. You would hope that as we press the button and repeat the 12 lead on these people, at some point the machine will pick it up. Sometimes it does, sometimes it doesn't. And I get it, there has not been a lot of 12 lead education in primary paramedic programs. There's not been a lot in continuing education, but we gotta have it. We have things that can fix this now, which we didn't have 20 years ago. So very important to be able to read a 12 lead. So. All right, to beat a dead horse, this is a little schematic I found on the internet. It kind of shows you injury patterns. 1 AVL, lateral, 2, 3 in AVF, inferior, V1 through V4 is your left main, septal anterior. And if you're up in AVR, that means you probably jacked up both the right and left main coronary. It could be bad. So for those of you that watch EMS Challenge frequently, I know I beat 12 leads down. I was gonna say I'm sorry, but I'm not. It's just pretty important that we get these things, folks.
There are a lot of things we do in medicine that we think we know what we're doing, but we really don't. And there are some things in medicine we know we can fix and make a difference. If I have someone that's altered, they're drooling, what is one test you get on all these people? Glucose. And why do we get a glucose on these people? Because, praise God, because we can fix it. Yeah. If dude's got a head full of blood, I can't fix that. You can't fix that. A lot of times the surgeon can't fix that. But if the guy's glucose is 20, I can fix that and take them from fixing to die sick to not sick, mad at you, calling your mama names, wanting to PRT, right? So that's important. Same thing with these 12 leads. Some things we can't fix, but STEMIs, for the most part, we can fix pretty good if we recognize it early and get them to the appropriate care. Sweet. All right. Let's talk hypertension a little bit. And the reason I do that is because everything's going category A, and the protocols do have drugs you can use to treat hypertension. And I want y'all to know what I think about hypertension and how often I use hypertension medications in the ER, which is rare. Okay. So hypertension, the ER physicians, we use a blood pressure of 220 over 120. Unless your blood pressure is that high, we care, but we're not concerned. When somebody comes and says, hey, the guy in room 4's got blood pressure of 210 over 116, I'm like, cool, be there in a little while. I'm not concerned about it. Now they say guy in room 4's got a blood pressure of 200 over 100 and he's sweaty and can't breathe. I'm putting down my Monster and my cigarette. That's a joke, no cigarette. And I'm gonna go see the guy right now. Does that make sense? So when you think about hypertension, we treat it in the ER or for you guys when they have signs of end organ damage. That means when they're sick, when I'm concerned about them dying in the next few minutes. All right. So hypertension, guy, blood pressure 200 over 100. He's 400 pounds. He's sweaty. He's breathing 30 plus times a minute. He can't talk to you. And he's huffing and puffing using accessory muscles. All right. That guy, I'm going to treat his hypertension because I think what's going on with him? He's in pulmonary edema, congestive heart failure. His blood pressure is so high, his heart can't pump the blood out of his little bitty lungs and through his big body. All right. So we got drugs out there we can use like labetalol and so forth, okay, or cardizem that you can carry now. But what drug is better for this guy who's obese, congestive heart failure, can't breathe, and hypertensive? What's a better drug for him? Nitro. Yeah. So we treat the underlying problem. Nitro is going to lower his blood pressure, fix his heart problems, and make him breathe better. So probably not a reason to give this guy labetalol in the field or metoprolol, any of the newer drugs you can carry. Sweet. All right. So this is a little lady. She's young and vibrant at 50, got a blood pressure of 170 over 100, heart rate's 80-ish, respirations are 16 because that's the number we like to put down there if we think we're kind of sick, right? Who knows what it was, but she's not working hard. Her sats are fine. Her glucose was normal. It was like 190. That's normal for Alabama, isn't it? 190. Nobody thought that was funny. And she says she's short of breath, chest pain, headache, I don't feel good. So that's her 12 lead. Too fast, too slow, or okay? I said, okay. I'm going to do my injury patterns, and I got some T-wave inversions here that make me uncomfortable. It's not a STEMI, but it makes me think, yeah, you may have some underlying heart disease either in the past or today. 2-3 in AVF, that's a little weird, but it's just in one, so not bad. V1 through V4, I got T-wave inversion, but it's not depressed. AVR looks okay. I'm gonna look at my intervals. P interval's fine. QRS is narrow. My QT is good. No reason to go over here because my QRS is fine. Before I put any EKG down, I look at it a second time because sometimes I'm talking too fast and thinking too fast. So I run through one more time, make sure I'm not missing a STEMI. Now I'm done, I lay it down. So it's EKG is abnormal, but it's not a STEMI. Not super concerning, but a story is. So now the folks want to say, well, her blood pressure is 170 and 1 over 2. We're going to treat her with some medicines to get her blood pressure down and make her feel better. All right. I think I have a slide on labetalol. So labetalol, approved by the state to be given for hypertensive emergencies. Does this lady need labetalol is my question. I would say no. She's not in extreme. She's not in distress. If she said she was having chest pain, is there a better drug to give her? Just like in CHF? There is. Pop a nitro under her tongue instead. And I'd say probably not a good idea to give her labetalol at this point. I would also argue that most folks in Alabama are unhealthy. the ones that we see, and maybe 170/100 is her normal blood pressure. All right, so I take her, and if she's feeling bad, feels weak and dizzy, and I give her labetalol, and I drop her heart rate by 20 points and drop her blood pressure by 20 points, she's going to feel even worse with that. All right, so I think that if you're concerned about her chest pain, she gets nitro. If you're concerned about her blood pressure, you rub her hand until she's going to be okay. Sweet. So things to think about. The betalol is a relatively safe drug for most people if used appropriately. The textbooks talk about you don't give beta blockers to people who just smoke some crack cocaine, because now they're hypertensive, they're tachycardic. You give them a beta blocker, what you're going to do is you're going to slow their heart rate down, but the blood pressure is going to get even higher. The betalol is a little bit different, probably fairly safe in cocaine use, but still not really a big indication in the ER or pre-hospital world for labetalol in this patient. What about this guy? Wife says that he was started talking funny about an hour ago. Blood pressure is 220/120, and he can't use his left side of his body. Got slurred speech. What's going on with him? He's having a stroke, right? All right. Our Clemson just beat Alabama, and he's an Alabama fan, 1-2. That was funny. So having a stroke. So he's hypertensive, having a stroke. You put him in the stroke system, you start moving toward the hospital. What are you gonna do for his blood pressure? You got labetalol in your drug box. You gotta do something. Does he get labetalol? Yes or no? Who says yes? Raise your hand. Nobody's gonna say. Who says no? Who says, I'm not gonna answer you? Good, thank you, sir. I like that. Very good. Appreciate it. Yeah. Yeah, I would say no too, right? Because there are two types of strokes, right? There's ischemic and hemorrhagic. If dude is having an ischemic stroke and there's a blood clot in his brain, limiting blood supply to part of his brain, that blood pressure response is salvaging the rest of his brain. It's getting more blood supply to his brain. So if he's having an ischemic stroke and I give him something to drop his blood pressure, I'm gonna make his outcome worse. Okay, and that's one of the things we don't want to do. We don't want to hurt people. One of our rules is don't kill people, right? Or make them worse. All right. Now, if he's having a hemorrhagic stroke where the vessel was burst and it's pouring blood into the brain, then you got to get that blood pressure down. You want it down quick. You want it down to 140, 160. How can you tell a difference in the field? That's the answer I like. Yeah, you can't tell. Okay. You got to have a CT scan, which you guys can't have. So even if he came to the hospital to me and I'm looking at him, I'm like, yes, sir, you've had a stroke. Your blood pressure is too high. He's going to go to CAT scan, and I'm going to follow him over, and I'm going to look at it. If he's got blood in his brain, I'm going to lower his blood pressure right then. If there's no blood in his brain, I'm not going to do anything to that blood pressure. There's no way to tell without a CT scan. Now, there are some hints, right? So you got somebody that has horrible headache, sky-high blood pressure, and they're rapidly declining. They go from talking to you to gurgling their speech to now drooling and not moving. That's probably blood. But I'm still not going to treat the blood pressure until I know for sure. But my mind's thinking, oh, dude, he's had a big head bleed. This is not going to go well, right? Versus the person who has new symptoms, they're having a stroke, they're hypertensive, and they're not progressing, probably ischemic, right? But again, you got to have a CT. My point to that is there's no, my opinion, there's no role for blood pressure management in acute strokes in the pre-hospital world until you can tell me that there's blood or not blood in their head. You can make somebody worse. Trying to figure out what this one is. I can't even see that now. Yeah, this is same thing. So a little bit hypertensive. They have a headache. They're neuro intact, but bad headache. Blood pressure is 180/70. Do they need blood pressure control with a headache? They do not. They need pain management. Okay. I love that picture. Come into the web of blood pressure control. Remember, the numbers that we get concerned about in the ER is 180/120. We treat the underlying problem first before we treat the blood pressure. Remember, a lot of folks in the South have hypertension at baseline, and maybe that 180/100 is normal, okay? I would argue if they have hypertension and congestive heart failure, they get nitro and BiPAP and you manage that. If they have hypertension and they're having a big STEMI, they get nitro and you manage that, okay? If they have hypertension and they're pregnant and they're talking to you and then they seize, that's bad. What drug do they get? MAG. They don't get labetalol for the blood pressure. They get MAG, benzos, airway, and an OB doc to take the baby out. Very good. So treat the problem, not the result of the problem, which is blood pressure control. I see more people hurt with blood pressure medications than helped for the most part. This one, too fast, too slow, or okay? Too fast, yeah, rate's about 140 plus, makes me a little uncomfortable. So then you can say, is it narrow, wide, complex QRS? I would argue it's kind of narrow. Machine says what was the QT? 50, yeah, so it looks fine. So is it regular or irregular? Right, so if you trust a machine, it says AFib, you're going to say irregular. I would argue again, touch the patient. If you touch the pulse and it feels irregular, it's irregular. If you touch the pulse and it feels regular, it's regular. That's the way you cheat. Easy to tell with slow heart rates. When you get rates up above 180, 190, they all look regular on that paper because it's so close together. So touch the patient. Or there's a device you have in your jump bag. It's probably dusty. It's got 2 prongs. It goes in the ears. And a thing that you listen to, put that over the heart, and you can say if it's regular or irregular, okay? So good use for that device. All right, so treatment for AFib RVR. How do you treat somebody that's an AFib with a heart rate of 150, short of breath, soft blood pressure? What are you going to do for that patient? So I hear cardizem, I hear hugs. Is that what you said? Good, good. Yeah, they look pretty good. So you got to remember, AFib RVR is the tachycardia of folks who have AFib. So if I've smoked for 30 years and now I have AFib and I go out and cut my yard, I'm going to get tachycardic and I'll be in AFib RVR. Just like if I have sinus rhythm and I go out and run steps, I'm going to get tachycardic. So AFib RVR, you treat the underlying cause first. All right. So kind of a push. Cardizem is out there. I would argue that anybody in AFib RVR, you look for the underlying reason. So are they dehydrated? Do they have a fever? Are they septic? Are they anxious? I would try fluids first for the most part, all right? Because there are some risks. Cardiac output is heart rate times stroke volume. People with AFib have low stroke volume. The heart doesn't beat fast, doesn't beat well. So sometimes they have to have a fast heart rate just to keep up with the perfusion. So there are some risks to cardioversion, okay? Now this is her in the back of the truck. Heart rate goes to 190. Blood pressure drops to 70. She is altered. Now how can you treat AFib RVR? Time, sir? To weld her? Oh, okay, I didn't know what that meant, to weld her. I didn't know what that meant. Yeah. Right, so can you give cardizem now? Blood pressure is 70, heart rate of 1? No. So you really can't give cardizem. Now it's synchronized cardioversion. Most folks in AFib RVR are going to do fine long-term for you. There's a subset of people who have really bad heart failure, and they have to have that fast heart rate to perfuse the body, but as they progress in the disease, they get worse, obviously. And these folks, if you cardiovert them, once you cardiovert them and slow that rate down, they actually get worse. My point to all that rambling is if you cardiovert somebody in AFib RVR, already in your brain have a backup plan that if they get worse, you're going to have to hang some dobutamine or dopamine or epi infusion to get them back up again. AFib RVR that doesn't get better with a little bit of fluids, a little bit of medications is super scary, hard to manage. In the hospital, we have some other drugs we can do. We can do a beta blocker called metoprolol. We can use esmolol. We can use esmolol as a beta blocker. Even if they're hypotensive, we can slowly drip that in there. Digoxin is still out there. We can do dig, all right? And there's another medicine called Corvert, which basically is a chemical cardioversion. It's a one-time dose, and it knocks them out of AFib. But again, if they have a really sick heart, bad heart disease, and you slow that rate down, there's a big risk they're going to decompensate. But the risk of cardizem is sometimes slowing them down too much. So just be wise when you use your cardizem. What else can you do? If you give somebody cardizem and the heart rate goes from 140 to 70, and now they're hypotensive, what other drug can you give them to fix your cardizem? Anybody know? Calcium, yes sir. So cardizem is a calcium channel blocker. So if I gave somebody too much calcium channel blocker and now their heart rate is 70, the blood pressure is low, I'm gonna use profanity, I'm gonna get sweaty, and I'm gonna look for that yellow box in my drug kit and give them a little bit of calcium to fix that, okay? It's sort of like what drug do you give somebody when you actually give them 200 mics of fentanyl instead of 25 mics of fentanyl, they quit breathing. What drug can you give them? Narcan, right? So there's a backup plan with cardizem. All right, this is a young female, palpitations, blood pressure is 140/70, breathing about 20 plus times a minute. She's at 98%, not working hard. Her D-stick is 99. Been doing some Red Bull. Too fast, too slow, we're okay. Too fast, right? Greater than 150, I can count it out. 300, okay, I'm done, right? So way fast. Narrow complex, so what is this? SVT, right, yeah. You also with SVT, classic SVT, you see that you're elevated in AVR some. That's also an indication. How do you know if it's regular or irregular? What do you look for? Feel the pulse, praise God. Yes, sir, just touch the patient. They like that, touch the patient, right? Cool, so we said it's too fast, it's regular, and it's narrow. So adenosine is a drug of choice for this. What's the dose that y'all can use? 6 or 12. I like 12 in the hospital, but state says 6 or 12. You're not going to have to call for this anymore. All right. So this is given rapidly. Give it real fast. If you push the adenosine and you look at your IV fluids and bubbles are showing up in your IV fluid, what does that tell you? Went the wrong way, right? Ain't going to work. So adenosine. Remember, SVT is a re-entry circuit, dysrhythmia. So there's a pathway somewhere in the AV node that's going really fast and refiring. When you give adenosine, it blocks it for a second, and that allows the heart to reset. Are there any people or any that you can't give adenosine to, or any risk to adenosine that you can think of? Yeah, me either. Yeah, so some people say if they have asthma problems, you have issues. Adenosine half-life is so short, not really a big problem. The only people I don't give adenosine to are two types of people, 3. If they're allergic, right? 2, if they don't need it, I'm not going to give it to them. And then 3, if they have a Y-complex tachycardia, it makes me uncomfortable. Because they could really have, with the Y-complex tachycardia, if it's irregular and it's AFib with a rapid rate, they have an accessory pathway through this septum here, and I block the AV node, you can take it from AFib, RVR to VFib. And all of that's cool for me, because then I can shock them and do things. They don't seem to appreciate it too much. That is a relative risk. American Heart says that if you have a Y-complex QRS tachycardia that you think is SVT, go for it. That's not what I do, but just food for thought, since you guys will be doing this Cat A as of end of April. If you Google SVT, you get this band with these people in it. I'm not sure what that is. Anybody know who they are? SVT, I don't have a clue, but that's what, if you Google, that's what you get. When you give adenosine, I would recommend that you keep them on the monitor and hit print, because it gives you some data. So adenosine, you push it and you got them on the monitor and you print this thing out and you recognize if it breaks, we're happy. If it doesn't break, then we can go back and look at it and say, okay, actually that was an atrial tachycardia, not an SVT, because we can see that rhythm, and it's beneficial for us. It's beneficial for the cardiologist to have that information. Then they can determine what medicine, what procedure to get them out as an SVT next time. So it's nice to do. The other thing I would say is when you give adenosine for SVT, you should break it at some point. If it's not breaking the rhythm even for a few seconds, the medicine's not getting to them. Something's wrong. The IV's bad. It's going up the wrong direction. You're giving it slow. Maybe you gave thiamine 3 times instead of adenosine. Double check what you're doing. You laugh, I laugh. It ain't funny. But the patient should have a break in the rhythm, and they should have this impending sense of doom for a few minutes. So I used to tell them, this doesn't hurt. We're not going to shock you. I push the adenosine. However, after I push it, I say, however, you can feel like dirt for a couple seconds. Just hang on. It'll be okay, right? A lot of people put the defib pads on them. I usually do not. You can if you want to. There's limited risk if they have a narrow complex tachy. You're not going to drop them in asystole. But if you want to put it on there, that's fine. Sometimes it is beneficial if it's a really big guy and they're hairy and they're sweaty. That keeps the leads on, so you know what the rhythm looks like the whole time. But just food for thought. Too fast, too slow, we're okay. 300, 150. 100. So a little bit fast, but okay-ish, right? Look for injury patterns. So intervals, QRS looks all right. I'm gonna look at it one more time before I lay it down. So STEMI or no STEMI? Yeah, I'd say it's a STEMI too. Machine actually says it's a STEMI, right? Again, machine is not completely accurate. When the statewide STEMI system goes into effect, if it says this, you still put it in the system, even if you don't believe it. But I actually believe the machine as well. This is an inferior. So guy gets aspirin. What's the only contraindication to aspirin is somebody having a STEMI? No, I would argue if they've already had it, I don't trust them. People take allergic reaction, and then you ask, what is that allergic reaction? Every time I take aspirin, it makes me have upset stomach. Guess what? Hang on. Take the aspirin. What if they say I took 2 aspirin before you got here? If they got the aspirin bottle in their hand, you can believe them. But I can't tell you how many times people have taken Motrin, Aleve, Norcos, methadone, and call that aspirin, and it's not. They need aspirin. There's limited risk. An extra aspirin, my opinion, is not going to hurt, but no aspirin can make it worse. They get nitro if the blood pressure is high after IV access and get a fluid bolus. I give these people O2, even if they're not hypoxic or saying they're short of breath, and I call it pre-oxygenation because STEMIs, biggest risk of death in this first 4 hours is cardiac dysrhythmia. And if you got one guy in the back of the rescue and you're heading downtown, all right, and he goes into cardiac arrest, and if you already got him on O2, you can put your cigarette out, turn the O2 up, and now he has passive O2. You can yell for help, start CPR, etc. I also put them on defib pads. If they go into VTAC or VFib, charge and shock before you do anything else. You may get lucky, break them out of it, and keep on trucking down the road. If you're not lucky, you pull over and you run the code, right? So aspirin, nitro, O2. If you want to do the morphine, the old Mona, that's fine. If the blood pressure's fine, they're having pain, really doesn't help them clinically unless they're super hypertensive. I would, even fentanyl, if you wanted to, the state says you can. I would never give somebody having a heart attack ketamine. Does nothing for them except make them trip and wig, and now they get more anxious and upset, right? Cool. In the hospital, we can lyse them with T and K. In the back of the protocol book, there is a STEMI checklist. The state says you have to take that on every STEMI patient or stroke patient, fill it out and give it to the hospital. I know y'all do that, right? I would argue though, at least ask the questions, know what questions are important, write them on your glove. When you get to the hospital, tell the doc. If the patient's still awake and alert, maybe you don't have to tell a doc. They can tell a doc. He'll ask the same questions. But if the patient becomes altered, obtunded, go into cardiac arrest, now they can't talk, you're the only one that can get this information, and you can decide whether or not I'll lyse them or don't lyse them for their heart attack. So get the information, record it the way you think is appropriate, and share it with the receiving physician. He needs that. Yes, sir. Yes, sir. Yes, sir. Chief Ford can answer that more on the operational side, but in theory, yes.
Yeah, so the question is, in BRIMS, we are using the STEMI part. We are using ATCC for the STEMI system, and we have modems on our monitors, and we send the 12 lead to TCC, who forwards it to the receiving hospital.
Right, and
that initiates a STEMI alert.
Right.
What the hospital does with that STEMI alert, I think, is probably varies a little bit hospital to hospital.
It does.
And staff to staff. But for the most part, you're getting the ball rolling. In the best case scenario, you as an EMS provider are really you're cutting a lot of time off of that STEMI to balloon period.
Right.
How you mentioned the different facilities handle it differently. Well, one of the takeaways, like with us using the stroke system, just for example, when we get the feedback and we see that we're assessing accurately and these patients are receiving TPA, then that's a success. One of the discouraging things is if a facility doesn't use the 12 lead to activate the actual CAT team. So does that come back on feedback in the BRIMS region as far as, yes, this was identified as a STEMI. Yes, you narrowed the time by 10 minutes
Yeah.
for the team. Those kind of things.
So that we get a patient outcome report to the system at the service level, and what we get there is whether it was a STEMI or not a STEMI, and some other data points. But sometimes they write the times on it, but I don't think that's standard. Wish it was.
Yeah, so we can talk some in the break too, but so each institution can determine what they're going to do with that STEMI alert, right? Some places you'll go from the field straight to the cath lab. Some places you stop and the ER doc reviews the 12 lead and you go from there. It just depends. But the benefit of the system, in my opinion, is the fact now the provider says, okay, patient has a STEMI, which hospital is available right now for a cath lab? And that's the one they're routed to. And there are good things to that, I think. Right. So, and then the other good thing is if you think about long-term, forever, we've all pushed to try to get patient data back to the field level provider. What happened to the patient, the outcome, share records. And that's been tough to do with the hospitals. Now, because hospitals want to be accredited as a STEMI center or heart attack center, they have to have that EMS data, first patient contact, first EKG, EKG to the ER, ER to the cath lab. They want that data. And so this is good for us because now we have that data that they want, and they have data that we want. So now we can kind of merge and at some point maybe make it a better system. But we can talk more about the break too. In theory, like Chief said, they should go from the modem to the TCC. Some places there's still technical difficulties. Sometimes I'll be working in the ER and across the tech will come out and hand me an EKG that's taken by a phone. It's a picture. And I can look at it and say, oh yeah, that's a STEMI. I'm talking cards right now before you even get here. So this is this guy's cath report. So there's his EKG, big inferior. And this is him where they go in, they squirt the dye. They can see that the vessel was occluded. They put a stent in, and now he's got great flow. So great outcomes for these folks. Very important stuff. So I know we're running short on time. I want Dr. Brown to come talk. I appreciate the work that you do. I will just stress that the work that you do is really important. And it's going to get more challenging. There's more responsibility coming with these categories going category A. You carry medicines that can save lives, and you carry medicines that if you get to the wrong patient, is going to kill somebody. And one, that's bad. And two, you're going to feel bad about it if you do that. So if you're not up to date with your medicines, with your rhythms, now is the time, guys, because it's fixing to get more real. All right. Questions, comments, statements within reason. We'll take about a 5-minute break and start back.
Hey, Doc, we do have a couple of things came in online.
Yes, sir.
So for one thing, we got people from all over the state checking in, which is nice. And we got Lifestar 3 out of UT in Sevierville. Want to make sure you got a Roll Tide. So they said Roll Tide.
Oh, okay.
I replied back, Go Tigers. I don't know if that's what I should have said.
I'm not going to make any comments, sir. I'm happy either way, sir.
But from a content perspective, we do have a couple of questions here. So one is that during the COVID season or even the flu season, do you see an increased incident with dysrhythmias, new onset of AFib or A-flutter, secondary to cytokine release?
I have not seen that. I'm not sure what the data shows on that either. I can tell you what I have seen is an increased stress on a system that was already near breaking point. And I see people that can't get primary care. We see a large increase in out-of-hospital cardiac arrest, a big increase in opiate overdoses, and a big increase in trauma. But I do not know that one, sir. I apologize.
Okay.
In 5 years, we'll have that data, though.
Okay, good. Well, someone also wants to point out that the correct medical term for someone who's hypertensive and very overweight is biscuit toxic. I haven't heard that before, but apparently that's the current term.
But yes, there's acute and chronic biscuit poisoning. Yes, sir, there is. Yes.
Right. And
That's when you say Roll Tide.
Roll Tide. And what about pulmonary hypertension? We've got a couple questions come in about, do we treat, can we detect, do we?
Yeah, so that's different. So pulmonary hypertension is increased pressure in the pulmonary artery and is usually due to underlying pulmonary issues. So previous PE, sarcoid, other things, interstitial lung disease, and those folks will get right-sided heart failure. You're seeing with the right bundle branch block. They'll get AFib earlier because that right atrium gets stretched, but it's not the same as hypertension like we think of, which is systemic hypertension. We ought to do a talk on pulmonary hypertension one day. We can throw that on the list.
Got it. All right.
All right. Thank y'all.
Thanks everybody for participating, and we're going to take just a few minute break and come back with Dr. Brown, who's doing a lecture on psych. So we'll see you back in here in just a couple minutes.
So my name's Julie Brown. I'm a ER doctor at UAB, but also doing an extra year of training in EMS. So I'm one of the EMS fellows. Today we're going to talk about behavioral health emergencies. I know that y'all see psych patients probably at least once a shift, maybe more. So something that's really important to talk about. So to define a behavioral health emergency, just think, or a psychiatric emergency, just think it's any acute change in somebody's behavior or conduct that's really not acceptable to that patient, to the person, to their family, to society. And that really can be somebody who just can't cope with a stressful situation. They had a loved one that died, now they're depressed, suicidal, or maybe they're psychotic. They're very violent and agitated. So these are the things we're going to talk about. We're going to talk a little bit about your assessment and treatment of the patient, your evaluation of them. Suicidal patients, we'll talk about agitated patients, talk a little bit about excited delirium and kind of what that means. And then we'll talk about the new protocols and then everyone's favorite drug, ketamine. All right, so we're going to start by talking about a case. We'll kind of come back to this case at the end, but just something for y'all to think about while we're going through the lecture. So you have a 35-year-old male walking in the street. This is the call you get. There's just a man walking in the street. So y'all get there, and it's a 4-lane highway, and there's this man running in traffic. You're like, okay. Oh, and he has a machete. So what are you going to do? You're going to probably wait for police to get there, right? You're not trying to get stabbed. Oh, he's like yelling things. And then somebody pulls up beside you in the rescue or the fire truck, and they say, he just told me he's going to kill me and kill everybody else. So this is like something that could definitely happen today, tomorrow, really any day, right? Maybe not the machete. Maybe a knife or a gun or something. Maybe. I hope not. Okay. So whenever you're assessing patients, your assessment of a psych patient is going to be very different than your assessment of somebody that has chest pain or a STEMI or a stroke, abdominal pain. It's going to be very different because you might not be able to talk to them. They might not be able to really communicate with you appropriately. But it's really important that we really fully assess these patients because they're really a danger to themselves and to others, right? And we don't want to leave them on the street to then go harm themselves or potentially harm somebody else. We might have to transport these people against their will. We do that all the time. And really just remember that law enforcement can help us. And something important to remember is that all these patients really do have legitimate problems, medical problems. Their psychiatric illness may be a primary psychiatric illness. Maybe they have schizophrenia and they're off their meds, or they never were on meds, or maybe they're, hypoglycemic and now they're agitated. Maybe they had a seizure, they're combative and post-ictal. So really their behavior might just be a manifestation of that disease, whether that's a primary psych issue or not. And then to remember that really EMS and then emergency departments are really usually the first line kind of entry point into the healthcare system for these patients. So y'all all know this, when you get on scene, you get a call out for a psych patient, or you get a call out for really for any scene, make sure that the scene is safe. I know a lot of places stage and wait for law enforcement to get there. So you don't want to go approach the patient until you know that that scene is safe and they don't have a knife in their pocket, they don't have a gun in their back seat or wherever they are. So like I said, there are a lot of medical problems that really can cause psychiatric illnesses. So patients that are, hypoglycemic and they're confused, maybe combative, maybe they're hypoxic and just really agitated because they have like a big blood clot, so they can't breathe. Or maybe they're lethargic because they're in shock. Maybe they got shot and now they're, getting hypotensive. They're really confused and kind of combative and fighting you and not letting you do stuff. Or maybe they are about to go in cardiac arrest. So we really need to make sure that we try to do a psych assessment the best that you can. Do you have a medical history of some sort of psychiatric disorder? And if you don't, we need to making sure that we check blood sugars on these people. checking a pulse ox on them, ask them about any medicines that they're on. So they might not think that they have schizophrenia, but maybe they're on Haldol at home. Ask about drugs or alcohol. They probably may or may not tell you, but it can really help your clinical decision making. And then do a neurologic exam, because patients that have neurologic problems can really present with psychiatric complaints. So if they're having a stroke, if they had a seizure, that's something that would be very different. You would treat them very differently than if this is a primary psych problem. So if you get on scene, the patient is cooperative enough for you to get vital signs and they're abnormal, really think about this patient as medically unstable, and they probably need to go to a hospital. Because their abnormal vital signs are probably a consequence of an organic problem. This could just be, their schizophrenia getting them very agitated, but think about it like let the hospital decide that, okay? So the kind of medical problems or medical diseases that can cause psychiatric complaints, these are a couple. So things to think about. So neurologic problems that can cause psychiatric manifestations, if they have a CNS infection, if they have an abscess in their brain, if they have meningitis, if they have encephalitis, these can all cause psychiatric or behavioral disturbances. If they have hypertensive encephalopathy, they might be very confused. If they have had a stroke, if they have some sort of tumor in their brain that's pushing on different areas of the brain, it might cause them to be confused. Seizures, we know people can get combative postictal or dementia patients. And then you think about your metabolic problems. So are they hypoxic and they're confused and combative because they don't have any oxygen? Are they hypoglycemic? Are they in acute kidney failure? So think about that patient who's been vomiting and having diarrhea for days, and they haven't been eating or drinking anything, so now their kidneys aren't working appropriately. Think about patients that are in liver failure. So if they have a big abdomen from their cirrhosis, maybe their ammonia levels are up and they have hepatic encephalopathy. And then you kind of get into the weeds of, is this hypothyroidism? They have Addison's disease. They have Cushing's disease. Is a cortisol problem that's causing their behavior. That's probably not something you're going to figure out in the pre-hospital setting. Probably not something I'm going to figure out in the ER either. And then you think about your drugs. So alcohol, amphetamines, bath salts, PCP. So those patients that might be, superhuman strength and fighting everybody, think maybe they're on PCP. And then withdrawal. So patients with alcohol withdrawal, patients with benzo withdrawal, they might be, combative. They might not want to participate in their care, and you might have a hard time trying to take care of them because they're really fighting you so much. But remember, alcohol withdrawal can kill people, and so can benzos. All right, so when the patients don't want to cooperate with you, you can try to get med control to help you. Sometimes they can talk to the patient, try to convince them to go. That's probably not going to work if they're really confused and they don't know what's going on. So you might have to try physical or chemical restraints, and we'll talk about those at the end. And then always remember that law enforcement can help. So if you get there, the patient's cooperative, they let you get vital signs, and they're all stable, maybe they don't need to go to the hospital. So you need to ask them, do you think that they're a danger to themselves or other? Are you suicidal? If you're suicidal, you probably need to go to the hospital, because the chance of you committing suicide later is probably pretty high, right? But if they're not suicidal, they're not homicidal, they have no thoughts of hurting themselves or others, and maybe they have a history of schizophrenia, they have been taking their meds, but every now and then they talk to themselves, they probably don't need to go to the hospital, right? So what do you do if the patient's refusing transport? Like, who should we let refuse transport? So I think if the patient can refuse transport if they have the capacity to refuse transport, that means that they know what is going on, they know why that they want to refuse transport, why they don't need to go to the hospital, and we'll talk about that in the next slide. So if they want to refuse, essentially you need to try to rule out the best you can a medical problem. So make sure that their blood glucose is fine, make sure they're not hypoxic, make sure their blood pressure is fine, they're not in shock. They can't be suicidal, they can't be homicidal, they can't be overly aggressive. So if they're violent and they're in a house full of other people, who's to say that if you leave them that they're not gonna harm everyone else. They have to have a psychiatric history. So if they're having a psych problem and that's what you get called out for and they want to refuse care, it helps for them to have a known psychiatric disorder. So if they have a history of schizophrenia, you know, maybe they're off their meds for a day, but they have an appointment tomorrow, maybe they can refuse care. And then hopefully they would have some sort of support, family, mental health, that they can go see their doctor tomorrow or something. All right, so let's talk about capacity. So your capacity really kind of describes a patient's ability to make a decision. So it's really fundamental for patients' respect for autonomy, so a patient's right to decide what is done to them. But that it's also an important part of informed consent. We are the ones that are going to decide if a patient has capacity or not. Y'all guys are going to decide that. We are not going to decide competence. So the difference between capacity and competence. So competence is defined by a court of law. So a judge defines you as competent. You in the pre-hospital setting, us in the hospital are not going to say somebody is competent. We're going to say you have capacity. Okay, so those are the differences. So in your chart, don't say this patient is competent because you're not going to deem them competent legally. All right, so a little bit more about capacity. So it's essentially the patient's ability to give or to take all the information that you tell them, kind of reason with that, and then make a decision that they want to refuse care or they want to accept care. And they have to be able to understand their risks, the benefits, the indications, etc. So the patients have to be able to understand what is going on, why you think that they need this. They have to be able to tell you that they want this or not. They have to appreciate their decision. So they have to be able to accept, yes, whatever decision that they make, and then know what could happen if they don't choose that. So essentially the things that you can ask is like, what do you think is wrong with you? If the patient can tell you, I have schizophrenia, I'm off my meds, I'm talking to myself, they might have capacity, right? And then you could say, well, I've recommended that you go to the hospital because maybe we can restart your meds. And they say, you know, no, I have them here, I can take them here. That's reasonable. You could ask them, you know, what could happen if we don't give you this treatment or if we don't transport you to the hospital? Why have we recommended this? Can you tell me what your decision is and how did you reach this decision? But really, this is just a way for you to decide if the patient is like processing what you're telling them. So you think that they have like a psychiatric or a medical reason to go to the hospital, and they say no, but they have to give you a reason why. So if they're like, I have schizophrenia, I'm not taking my meds because I ran out of them, but my dog is home alone and I need to take care of my dog. That seems like they're pretty reasonable. That's a good thought process, right? So I think that's reasonable. So those are why people leave like AMA in the hospital all the time against medical advice. All right. So another way to do this is is a patient alert and oriented. Alert and oriented does not mean that somebody has capacity. You can know what's going on, know where you are, know what time it is, know what year it is, and still lack capacity. But this is a good component. They can't be a danger to themselves or to others. They don't appear to be intoxicated or influenced by drugs or alcohol. If somebody is very intoxicated and stumbling around, then they probably don't have capacity. They don't appear to have an acute neurologic insult, so they didn't just have a seizure and now they're postictal. They're not hemodynamically unstable, and their blood sugar is normal. All right, so let's do some examples. So we'll go through some cases. So you have a 22-year-old female at the bar. She smells of alcohol, crying, saying she wants to kill herself because her boyfriend broke up with her. Does she have capacity? Yeah, no, definitely not. So whether or not she wants to go to the hospital or not, she's going to go. Whether you have to use restraints for her, it's going to be kind of up to what her behavior is. What about the 45-year-old that has a history of schizophrenia that's naked in the street, trying to punch people or punch vehicles? No, he doesn't have it. He needs to go. What about, this is pretty common, especially in the current state of things. A 35-year-old who you're called out because he's unresponsive, he has heroin beside him or needles beside him, you give him Narcan and now he's awake and alert. Does he have capacity to refuse care? No, it depends. So The police can take his bag of heroin. If he was shooting up heroin just to have fun, and now he's awake and alert and he doesn't want to go to the hospital, you don't have the right to take him. So that would be kidnapping. If he did it because he's suicidal and was trying to kill himself, that's different. So he needs to go to the hospital. But it's a little counterintuitive, I think, that a patient who essentially was almost dead can refuse care, but they can. What about the 40-year-old that has a history of schizophrenia, who's working, she's talking to herself on occasion at work, so that's why, she works at McDonald's and a customer called 911 because she's talking to herself. She's like, I'm taking my meds, I'm not suicidal, I'm not homicidal, I just talk to myself sometimes. Can she refuse care? Yeah. Exactly, yeah. Me too sometimes. All right, so really kind of key notes, medical clearance in the field's challenging. So really kind of err on the side of caution. And if you think somebody needs to be transported, then you should probably transport them. All right, so let's talk about the suicidal patient. So just a couple definitions. So suicidal ideation is really just the thought of having like the idea in your head that you want to kill yourself. You don't have a plan, you just have this thought in your head that you want to do it. Passive suicidal ideation is that you are just having those thoughts, you don't have a plan, versus active suicidal ideation means that that patient says, I have a gun at home, I'm going to go kill myself at 9 p.m. tonight. So that's pretty high risk, right? A suicidal gesture is really kind of a self-inflicted harm without the expectation of death. So those people that cut themselves kind of very superficially on their arms or their legs, they're not actually trying to kill themselves. They don't actually think that they will kill themselves. Versus a suicide attempt is that that patient thinks that they were going to kill themselves. So patients that try to hang themselves, patients that shoot themselves, etc. All right, so suicide is the 10th leading cause of death in the U.S. And it's the 3rd leading cause of death between, I think, 15 and 24-year-olds, which is really prominent. The most common methods that people kill themselves are firearms, suffocation, poisonings, taking too much of their medication. These are factors that correlate with a higher risk for committing suicide. I think the important things to kind of note for the pre-hospital is to say, if the patient is suicidal and you ask them, hey, have you ever tried to commit suicide before? And they say, yeah, I jumped off a bridge 2 years ago. Their risk of suicide in the future is really high. If they have a history of a psychiatric disorder, their chances of committing suicide are pretty high. If they have like a terminal disease, think like cancer, people with end-stage HIV. If patients abuse drugs or alcohol, they're more likely to commit suicide when they're under the influence. People who are recently widowed or divorced, people who are unemployed, and then older people. So white males over the age of 65 are the most likely to commit suicide. So women are more likely to attempt suicide, but men are more likely to actually go through with it and actually commit to be successful with their attempt. So if somebody is suicidal, always take that threat seriously, because up to 2/3 of patients who have committed suicide have seen a healthcare provider in the previous month, which is a lot of patients, right? So really your kind of intervention might be the last chance that they have before they end up doing it. So when you get on scene, obviously make sure the scene is safe, get law enforcement to make sure there are no guns or knives. I don't know if y'all can tell in this picture, but there is a man on the ground and then another man that has a knife behind his back. Be sympathetic, be empathetic. You don't have to agree with the patient, but just don't argue with them, okay? It's not gonna help. And then try to be compassionate and tell them, we're gonna do the best that we can. If the police are there and they don't like that, just tell them, this is just here for your safety, for our safety, just to help. And if patients if they don't come out forthright and say, I'm suicidal, I want to kill myself, if they, express that they're depressed, they're hopeless, my husband died 2 weeks ago, I have all these pills, I've considered taking them, just to go to sleep and never wake up, really consider that pretty high risk for committing suicide. There's been concern in the past that if you ask a patient if they're suicidal, if they don't forthright come out and tell you that they are, that it might induce a suicidal thought, but that's not been shown that's not been proven at all. All right, so if you have a suicidal patient, put them on the stretcher, fasten to the stretcher, don't let them sit on the side of the rescue next to the door because they might jump out. If they have belongings with them and law enforcement is not there to search their belongings, I would recommend putting the belongings in the front of the rescue away from the patient, just in case there's something in there that they can get. And then whoever has really established that best rapport with them should ride along. If the patient's not going to cooperate with you no matter what you tried, in the state of Alabama, you can involuntarily transport patients that are suicidal. And you might have to use restraints, and then you can use the police. And we'll talk about restraints in a minute. All right, so everyone's favorite, the agitated and violent patient that might need restraints. So there are about 1.7 million encounters with agitated and violent patients in the U.S. annually. I worked a shift yesterday, and I had at least 3 when I was working. So it may, just remember that their agitation might be a component of a medical problem, or it might be a component of a psychiatric disorder. So when you get on scene, really approach with caution, make sure you have law enforcement. If it doesn't really kind of come out as a psych complaint, but the patient's really talking loudly, kind of moving around constantly, balling up their fist, consider them to be violent. And patients that are more likely to be violent are those that have a history of psychosis, a history of paranoia, patients with bipolar disorder, and then patients with antisocial personality disorder. If they are considered a high risk for violence and law enforcement's already searched them, the scene is safe, don't leave them unattended because they might go harm somebody else, might harm themselves, but stay a safe distance away from them as best you can. If they're in the back of the rescue, don't let them block the exit. So you put your back to the exit. So don't let them in between you and the exit. Obviously, take away any objects that can be used as a weapon. If you have trauma shears, you might want to put those somewhere else. And then avoid prolonged eye contact because these patients might think that it's a challenge. And then try to verbally de-escalate with them. Don't argue back with them because they're not going to be able to rationally reason with you. All right, so we talked about this. So anybody that has a psych complaint needs a medical evaluation, glucose, oxygen, all those things. You might not be able to do it right away. You might have to restrain them first, and that's fine. But you just need to remember to do these things afterward. So if a patient, if you deem that they don't have capacity, so they're, psychotic, they're suicidal, and they're not cooperating with you, you might have to restrain them. So you can try to verbally de-escalate them. A lot of times that's not going to work. You can use physical restraints or chemical restraints, but make sure you're documenting this pretty well in your whatever system that you're using. So what did the patient look like when I got there? Why did I decide I need restraints? What kind of restraints am I using? And how am I assessing them after those restraints? Okay, those are all the important things. So you can try to verbally de-escalate them first, kind of respect their personal space. Don't be provocative. Don't be argumentative with them. Try to listen to them and say, why are you acting like this? What can we do to make you calm down so that we can take care of you? Set limits with them. So if you don't cooperate, we are going to have to restrain you, and just let them know that that's going to happen. Because sometimes there's just not enough time. The patient's too violent, and you just have to restrain them. So ideally, you would have 5 people. I know that's not realistic in most settings, but you would ideally have somebody for both arms, both legs, and then somebody holding the head to restrain somebody. You could have law enforcement help you, but just letting them know that this is for their own safety and for yours. If you have a patient that's restrained, don't leave them unattended. Make sure that you're monitoring their vital signs. Make sure you're monitoring their respiratory status, especially if that patient was prone at any position at any time. So there's a lot of things in the news about patients who are being held down, and then they kind of go unresponsive while their restraints are attempted to be placed. I would say if a patient is super violent and combative and fighting with you, and they're in a prone position and they stop moving, worry about them, okay? They might be having a cardiac arrest because they can't breathe. Maybe they suffocated. And then once you restrain them, you can kind of remove their clothes or have law enforcement search them, make sure they don't have guns in their pockets or knives in their pockets. I can tell you several times where I've been in the trauma bay at UAB, we've had trauma patients brought in who have guns in their pockets or knives that we cut off their clothes and they fall out. So patients have dangerous objects all the time. So restraints are really risky to not only the patient, but also to you, because patients can die in restraints. We talked about this, especially if they're prone. So don't transport a patient that's prone. Are they hogtied? Are they wrapped up? Make sure that they can breathe. They don't have anything kind of in front of their face. And if the patient's still struggling or they're still fighting, but they're sort of calm, I think it's nicer for you to use chemical restraints. Sometimes patients will be willing to take chemical restraints without getting physical restraints. A lot of times in the ER, I'll offer, hey, can I give you a medicine to help you calm down? And a lot of times they're like, yes, please give it to me, because they've had it before. So you could try that. If not, if they're super violent and they're mean and they're running from you, restrain them, and then you can physically restrain them, and then you can chemically restrain them. Yeah, so patients who get chemical restraints, really this can, you think that it can be risky, and it is, but it can also help reduce the risk of injury or death to these patients, because they might have this hyperadrenergic state like excited delirium, and when you chemically restrain them, it actually improves their outcomes. Because your goal in restraining these patients is to control their agitation and their psychosis. So ideal medicines for chemical restraint, so think things like ketamine, you can use Versed, Haldol, things that you can use IM. If you give somebody something orally, it's probably going to take 30 plus minutes to work, and you don't have that much time. So IM is really good, or intranasal. It has to have a rapid onset of action, but with a shorter half-life. You don't want them zonked for days, and then nobody can assess them, and the hospital can't get rid of them. And then you really want it to have a low risk of side effects. So you want them to be able to keep breathing. So whenever you chemically restrain somebody, make sure you're monitoring their vital signs, make sure you're monitoring their mental status. Think things like respiratory rate. If you have entitled nasal cannulas, those are good to use, because if they get ketamine and they start breathing 5 times a minute, it's a ventilation problem. It's not an oxygenation problem. So you need to bag these patients. You don't need to put oxygen on them. That's not their problem. And then anybody who gets chemically restrained should go to a hospital. If the police are there and they want to arrest somebody and they want you to give them ketamine first, if you give them ketamine, take them to a hospital. Don't let them go to jail, because they might go sit in a jail and stop breathing. All right, so a little bit about excited delirium. So it's a life-threatening condition of a hyperactive delirium and severe agitation. So these patients are hyperadrenergic. So they have a lot of catecholamines kind of running around. They're hypertensive, they're tachycardic, they're worked up, they're really violent. So all these things. So they have a high pain tolerance. They might be pacing or grunting. They're not compliant. They might be inappropriately clothed. So it might be 30 degrees outside and they're naked running around. They're very paranoid, and they usually have an untiring strength, meaning they can go on for hours doing this. But the thing to remember about patients who have excited delirium is that you cannot rationally have a discussion with them. If you tell them to stop, they're not going to be able to process that and think, I need to stop what I'm doing, okay? And it's usually due to a disordered neurotransmission of chemicals. So think things like dopamine, serotonin, acetylcholine, GABA. So they just have a disordered transmission of all these chemicals in their brain. And it might be due to an underlying medical issue. It might be due to drug use or other toxins. And it's really high risk for fatal outcomes. So these patients can get worked up for so long, for hours. They might have been worked up for 5 hours before you got on scene. And they can go into rhabdomyolysis, where their muscles are starting to break down, their kidneys can start failing, or their fatal outcome can just be due to their underlying condition. So we really need to kind of treat them as fast as we can to improve their outcomes. So this is the new altered mental status protocol that'll go live in April. We'll make it a little bit bigger. So these are patients with excited delirium. So things we want to do: check their blood sugar, check their blood pressure, check their heart rate, try to get access on them. But if they're not compliant with you and you have to restrain them first, I think that's fine. So you can try chemical or physical restraints, and then we can do chemical restraints. So the dose for ketamine is going to be 2 to 4 mg per kg with a max dose of 400. Or you can use Haldol and Benadryl. And why do we use Benadryl with Haldol? Anybody know? Say that again. Yeah, so you're going to try to prevent like a dystonic reaction. So patients that get Haldol can get really agitated and kind of worked up. They can have like weird twitching movements, which is why you give them Benadryl, or Cogentin is another one. All right, so big thing to remember, ketamine is based on your ideal body weight. It's not based on the patient's real body weight. And your ideal body weight is based on height. These are the formulas for ideal body weight. I'm not showing you these so that you remember them because I don't remember them. But just know that in the formula, it's height, it's not weight. So don't memorize these formulas. If for some reason you have a question, MD Calc has an app online, or you can just Google MD Calc and you can type in their height and they'll give you their ideal body weight. I know some agencies have like laminated cards of how much ketamine they should give somebody based on their height. But just remember that ketamine is based on height, not based on weight. Because if somebody's 400 kilos, 400 times 4 is a lot of ketamine. They probably don't need that, right? You might kill them. All right, so back to this case. So we have a 35-year-old that's running in traffic. He has a machete, and he's suicidal and homicidal. So what do y'all want to do with him? What's the first thing you want to do? Yeah, make sure your scene is safe. So let's wait on law enforcement. So once law enforcement gets there, he's not cooperating. What do you want to do? Yeah, you can have the police tase him. So try to interact with him. If he doesn't interact with you, you can physically restrain him once the police kind of get him down. And then I would probably give him a shot of some ketamine because it sounds like he probably has excited delirium and really high risk for bad outcomes. And then once you give him some meds, make sure you're monitoring him really closely. All right, so to wrap it up, really behavioral health or psychiatric emergencies really are a unique challenge for EMS, and they're a very common problem that we see. But your scene safety is really the most important thing. So wait on law enforcement to get there to make sure that the scene is safe. Don't try to fight or restrain a patient who is being wild and you only have you and your partner. Like, you need some more help. Don't leave patients who are restrained unattended. If you chemically restrain them, make sure you're not over sedating them. And if you are, make sure that you have a BDM ready that you can bag them. Make sure you know your protocols, which the new protocols will go out in April. Train frequently, and then call for backup if you need it. That's it. The one on the right is my favorite.
Hey, thanks, Dr. Brown. We got a couple of questions came in. One is, I think you kind of answered already. Is there a better way to administer medication other than dealing with a severely combative altered patient with an exposed needle? And I think the answer I heard was taser, taser, taser. Is that,
Yeah.
Okay.
Yeah.
Yeah. So along that line, we also had a question, what do we do when, and this seems to happen sometimes, what do we do when law enforcement's not really all that keen to help because the patient, they'll say they haven't committed a crime. They may be in their home having a psychotic episode, and oftentimes law enforcement says, I can't arrest them, they haven't committed a crime. So is there a
Well, we
role
don't want
from-
law enforcement to arrest them. We just want them to help us, right?
Right, so that's a important distinction, right, is them helping.
Yeah.
About 3 years ago, that issue came up because, you know, the bigger cities like Birmingham, you probably see excited delirium quite a bit. Well, Dothan, I'm speaking about Dothan, the first time or two that they had seen that, they didn't, one thing they identified is the need for PD to work with FD you had to work together, whether, you know, the tasing so that you could administer, then was Haldol, so on and so forth. So what they did was they created a 1-hour in-service, and they trained every police officer in excited delirium. They got on the front end of it, and they created a protocol, and it's worked great.
Good idea.
Thanks. Yep, it's a good answer. The more we cooperate. So if you don't have a lot of cooperation, I would suggest one way to start building a relationship is through mutual training. I think that's a way that people can come together from different agencies. If you know somebody's first name and you've seen them in training a couple of times, it's a little bit more difficult to be nasty with them on the scene, right? Somebody that you already know. So that would be a suggestion. So we've also got a question about the BRIMS region, when we're going, is doing the STEMI system and receiving 12 leads, but all places don't do that. So Michael Miner from BRIMS has commented in the chat, statewide STEMI system is in the early planning stages with ADPH, Office of EMS, Acute Health System Office, but no implementation date has been set yet. So it's coming, everybody hold on, it'll be going statewide. We've been doing it in the BRIMS region for many years now, and it does help. So. There's another question about certificates. A couple of questions about certificates have come in. I'm about to put, if you're watching online, I'm about to put a QR code up for you that you can scan and get the certificate, and that will help. Maybe you can also go to you can send an email to alabamaemschallenge@gmail.com. And that will get you an automated reply with a link to the attendance form. So if you're seeing a bunch of screens changing online, I apologize. I'm trying to get you to the QR code so that you can scan. We don't have any other questions online. Got any questions from the audience?
Still relatively new.
Uh-huh.
Ketamine's still relatively new to the scene. Does it give a positive response as far as that metabolic burn rate? You know, how they're burning that glycogen. Will it help counter that to promote, you know, better kidney outcomes thing?
I think so. Yeah. Everything that I read, you know, making this lecture, is ketamine was the first line kind of recommendation. And there is a kind of a paper that was put out by ACEP not too long ago about excited delirium syndrome and kind of recommendations for it, and ketamine's on there. Other things that you can think about, which I really like, is Versed in the hospital. I've used it in the pre-hospital setting, but you have to, you know, have it, and you have to call for med control to get it and to use it currently.
I think ketamine's great. It's category A.
Yeah.
I think the issues that from a physician side, and the doctors in the back may answer this as well. When ketamine first came out, I think the dosing was a little bit too high. You'd see people going from excited delirium, running butt naked down the street, to being bagged. So just remember with ketamine, the dosing is important. It's ideal body weight. If you can't calculate that and it's 2 in the morning, cut the dose in half. All right. The state also is maxing out ketamine to 400 milligrams for any one dose. I can tell you stories of getting calls and patients have got 750 of ketamine and they want more. And I'm like, they don't need more. They probably need an oral airway, right? So, and like Dr. Brown said, post-ketamine patients are critical patients. once they chillax and you can expose them, look for life threats, get an AccuCheck, get them on the monitor. If you have capnography, use capnography. So if you see that rising or they're not breathing, then you assist ventilations. Like Dr. Brown said, people post-ketamine probably don't need oxygen for oxygen issues. They're hypoxic because they're not ventilating. So poke them a little bit, put a nasal trumpet in, open the airway. If they get better, great. If they don't, then they get a bag, put the mask, ventilate with oxygen that way, okay? If you have not been watching the news, there have been a lot of issues in Colorado with ketamine use. There's some strange laws coming because of that. There are people, EMS providers, criminally charged. So like Dr. Brown said, if you give ketamine to someone in the field, they cannot PRT, they cannot go to jail, they have to go to the hospital. Now, obviously don't tackle the cop, okay, but state your case with that. On physical restraints, nobody goes prone, people die from that, all right? The other thing is you can't do sandwiches anymore. Y'all know what sandwiches are? 2 backboards, and you handcuff them together and the guy's in the middle. That will get you in trouble. And then don't forget that there are cameras everywhere you work. In our hospitals, there are cameras, but in the field, everybody's got a cell phone. Just remember, what you say is being recorded, what you do, your demeanor can show up later in court. So, you know, treat it like it's your wife or your husband. Smile and nod, be pleasant. You can have your bad thoughts when you get away from them, right?
Because the police probably have cameras on too.
Exactly. And the mention about what do you do if law enforcement doesn't help, remember, even if you call med control and say, hey, I got this naked guy pole dancing on a light pole, I need orders to restrain, give ketamine. I'm like, sure, do it, whatever. I cannot give the police a legal order. I have no authority over law enforcement. That's a different chain of command. You don't either. But you also do not have an obligation to get hurt or beat up. So if the guy is swinging sticks, knives, or chains, and the cops don't want to get involved, you don't have to get involved either. Up front is the best way to manage that, but I can't tell you, I've had numerous calls at 2 in the morning from places that law enforcement did not want to get involved, and I'm like, hey, my order is that they need to be restrained and treated, but you have no legal obligation to get hurt doing that. So you tell law enforcement, thank you for your service, we're leaving. And usually that changes the tune too. There was another case of ketamine use. This one was in Kansas City, and it was a patient that was a GSW to the head that they deemed was non-salvageable, but the patient was still having moaning, and they gave ketamine use for that. And you can Google that, but I won't go into details. The point of that is use common sense. People that you're not going to resuscitate do not need sedation, okay? That'll get you in trouble, and it goes back to everything's on camera. And then there was a question at the break about what I was saying about oxygen use and STEMIs. So let me clarify. American Heart says that you don't use oxygen on someone that is not hypoxic because there's a chance of free radicals and people get worse outcomes down the road. All that data is done from the ICU side, inpatient side, and folks in high flow O2 for more than 8, 12, 24 hours. When I have a STEMI patient, I do pre-oxygenation, and I do it on the aspect that if I'm in the back of the truck by myself and they're sick, and I know they're having a STEMI, there's a high risk they can decompensate. So they get O2, nasal cannula, they get defib pads. So if they go into cardiac arrest, I can charge and shock, do passive O2 while I'm yelling for help. Hospitals sometimes will not like that, and that's okay. But there's no data that shows low flow O2 for short term is bad. But you will get fussed at hospitals, okay? So just make sure everybody's on the same page and know why you're doing that. If need be, if you're pre-oxygenating your patient and the O2's on, as you head into the hospital and you know their sats are 96% and you know that somebody's going to slap you, turn it off. You're at the hospital now. Now you have resources that kind of change the playing field. Does that make sense? Okay. The other thing, remember, you're EMS, I am ER. Nobody likes us, right? And you're going to get in trouble no matter what you do. So make sure you're doing the right thing, that you can go home with a clear conscience, because doing the right thing or the wrong thing, you're going to get fussed at. Other questions, comments, statements within reason? Right.
I would just bring up the recent Colorado case involving EMS and law enforcement, the use of ketamine and other drugs. So that case involved, if I'm remembering correctly, the police officers on the scene asking or instructing EMS providers to give ketamine as well as benzos to calm the patient down to help them arrest the patient. So I would just suggest to be careful there, because that patient in that particular case did not have the indications for those drugs. It turned out there also wasn't probable cause to arrest the patient, and everybody got in legal trouble, both civil and criminal. So you have to apply common sense. You have to do what's right for the patient and work together with law enforcement to whatever extent that's possible.
Question before we go. How many folks here have ever been assaulted while on the job? Okay. How many folks have been assaulted by something minor, like somebody spitting at you, throwing poop at you, things like that? Right. Cool. Anybody ever been stabbed or punched or attempted to be? Anybody had a weapon pulled on you?
Mhm.
Yeah. So Dr. Brown mentioned something earlier. The world's crazy, folks. You got to be safe. I cannot give you specific numbers, but I can say that probably over 30 guns have been taken off patients at a patient that I work in the past year. 200 knives, a bunch of mace. Like you said, I've cut clothes off people and guns have fallen out. There was a GSW to the head in our ambulance bay at UAB a couple of years ago. You can Google it. It's on the news. A patient came in by EMS, came out of the back of the rescue, and then pulled a gun out of his bag that was in the back of the rescue with the medic. Scary stuff. So we got to be safe. And I think the other thing we got to do is there's got to be a way to register when we get assaulted or hit or spit on so that people know what's going on. I know just me, I work in the ER 99.9% of my time, and I've had things thrown at me. I've been punched. I've been bitten. I've been approached in the parking lot with people. So we need to make a registry for that at some point too, to show what we do. So now I'm just rambling. I'll leave you alone. We got skills lab at 12:30. If you're in the area, come by. We're going to do advanced airway. If the ultrasound charges, we're going to do the ultrasound. We got pig trachs, and we got a Lucas and a defib tech practice with.
I'm so proud of you for getting that name right.
All right, good.
Yep.
Thank you. All right.
Hey, thanks everybody for being here. Please stick around. We got lunch provided. Then we're going to have skills. If you're in the area and you couldn't make it for live lecture, please come by and join us for skills. We'll be doing skills from 12:30 until 2:30. We'll get lunch going here in just a few minutes. Once again, even if you don't need the credit for National Registry, please fill out our attendance form. It's an opportunity to get your feedback about this class and our program. And we read every word of the feedback, and to whatever extent we can, we accommodate suggestions. So please do that so we can keep making this better for you. This is all about you guys working in the field and helping you do your job better and giving you more resources. Thanks to the Alabama Fire College for being our sponsor. They're the reason we can take this on the road. They financially support us. And thanks to Enterprise Rescue for hosting us here today, and the Enterprise Civic Center is a great venue. And thanks for everybody online watching. We'll see you next time.